Hello, East Coast, West Coast, and across the world to our international audience. My name is Adrian Dana. On behalf of the ASMBS and the Bariatric Surgical Training Committee, I would like to welcome you to this edition of the Fellow Lecture Series. Joining me this morning is my great co-moderator, Dr. Kunoor Jain-Spangler, and for the West Coast rebroadcast, we have Dr. Judy, Chen, and the chair of our committee, Dr. Matt Martin. So our goal, of course, has been to bring the world of bariatric surgical education together with high-quality lectures and content experts from across the world. And we have done that for the past year, and this is a reminder that this will count towards your application for a certificate of additional training, whether you watch the lecture on demand through the ASMBS video archive or live. We want to remind you that if you haven't started on your application, this is a good time to start looking at some of the components that you have to bring together. And also, as you transition to practice, you're always welcome to join our lecture series and learn a few more things with us as we move into the next academic year. Our topic today, access to care and insurance coverage obstacles, is truly central to what we do as surgeons. Upon starting your career, you will realize, if you haven't yet, that there's a lot more to it than just operating. Advocacy for your patients is a responsibility that comes with being a surgeon. Today, we have two great speakers and leaders in this very important domain of our practice, Dr. Joe Northup and Mr. Walter Lindstrom. I'll start by saying a few words about Joe. Certainly, I don't think he needs much of an introduction in the circles of bariatric and metabolic surgery. Dr. Northup was recently elected to the Executive Council of the ASMBS. He is a past president of the Ohio and Kentucky chapter of the American Society of Metabolic and Bariatric Surgery. And he is the outgoing chair of the Access to Care Committee, where he has done some tremendous work and led some great victories over the last few years. He has led the fight nationally on behalf of the ASMBS, on behalf of our fellow surgeons, and on behalf of our patients for the better part of a decade. And you will find out from him how you can get involved and what are the current initiatives are. It is also a great pleasure for me to introduce our other speaker this morning, Mr. Walter Lindstrom. I met Walter about 15 years ago as I graduated fellowship at a gastric band course where he was on faculty. We happened to be seated at the same table, and at that time he left an impression on me about his passion to advocate for patients with obesity. Walter graduated cum laude from the University of San Diego in 1986, and in 1987 was admitted to the bar, the California bar. He established since then a non-legal patient advocacy practice to support patients who are having trouble with insurance coverage and with benefits for this very important therapy for obesity. It's important to know that Walter himself is just now recently celebrating his 27th anniversary from his own open gastric bypass surgery performed in 1994. He has himself struggled with obesity since childhood, and despite being an insurance law expert, he has had trouble getting coverage for his own care. He has formed the Lindstrom Obesity Advocacy along with his wife and has handled more than 10,000 insurance claims, assisting patients to get the life-saving therapy that they need. So we truly have a wonderful, wonderful couple of speakers this morning, and we're looking forward to their lectures, as well as some great interactive questions. Also a reminder that if you do want to ask a question, please use the Q&A portion and feature of the Zoom platform, and we will get to as many questions as possible. And a reminder that there will be a separate Q&A session for the West Coast rebroadcast. So without further ado, I'm going to introduce and yield the floor to Dr. Joe Northup. Joe, take it away.
Good morning, Adrian. Thanks so much. I appreciate you guys involving me in this process. I'm happy to speak to the fellows this morning. Let me pull up my screen. And if you guys can see. There you go. Guys see that okay? Great, thanks. Well, good morning, everyone. As Adrian said, I'm Joe Northup. I'm a bariatric surgeon and have been pretty active in access to care for our patients for several years. And so I did a fellowship right around 15 years ago. So I guess I'm getting old and I don't realize it. But so I was once a fellow as well. And things have certainly changed a lot during this time. And I kind of want to focus a little bit about, what you kind of expect as someone coming out. And when I came out, it was more like looking at, I want to be a doctor and I'm going to take care of patients, and that's going to how I work. And then you get kind of in your practice a little bit and you realize that there's a lot more to it than just the clinical care aspect of it. And especially when it comes to bariatric surgery, it's more than any other specialty that's out there, how much we have to deal with getting our patients not only into the office to get them taken care of from a clinical standpoint, but actually getting them to the operating room or getting them taken care of from an insurance standpoint. So it's quite a bit different than in other specialties. So this is my disclosure slide. So first we talk a little bit about, why this is important and why obesity has such impact on our patients and our society. We currently spend over nearly $2 trillion on weight and weight-related diseases, and this is increasing over time. And the reason this is so impactful, when you look at someone with a high body mass index, they're over 40% higher just to take care of, just to manage in a healthcare plan with all their expenses and related to their healthcare costs. So if you can imagine the impact we have on society, this is where bariatric surgery makes a big, not only clinical impact, but financial impact for insurance companies, for the patients, for our overall society. So next I want to show is what we call these coverage heat maps. This is kind of a tool that we use from an access standpoint to tell us, how we're doing and how we're getting coverage across the United States. So this is our first one. We look at state employee coverage and we look at broad groups. So this currently is where we stand and what percentage of our states have coverage just for bariatric surgery for the state employees. So you can see that it's not ubiquitous. You have people that work for the state government that do not have coverage and cannot get bariatric surgery despite having health insurance. So I will say we're pleased to say we just flipped Louisiana over. We just had a big access victory in Louisiana, where as of I think immediately starting in this month, they do have access care to bariatric surgery now. So that was a big win. So we still have a few other states, especially South Carolina and Georgia, as our next targets to get state employee coverage. And so this is there we go. So under 18. So also a big push has been adolescent bariatric surgery from the Academy of Pediatrics. So we've been kind of tracking this as well. So again, some states have coverage. This is a little bit more of a challenge to get coverage for adolescent bariatric surgery, regardless of how you personally feel about doing surgery on under 18-year-olds. But there's a lot of yes states, no states, and still undetermined in many states. So Medicaid, this is something that we have been very aggressive on getting covered now. So again, only 2 states do not have coverage for general Medicaid. We'll talk in the next slide. When we see this, sounds good for coverage, the reality is not always as good as what the documentation states. And then again, under 18-year-old, the essential health benefits. This is where kind of our holy grail right now with the Affordable Care Act is getting designated bariatric surgery as an essential health benefit. So when the essential health benefits came out, you look at the 10 items that were listed, obesity care is not on there. We had been hopeful that obesity care would be considered under the chronic disease management category, but it was not. So so getting listed on the Affordable Care Act as an essential health benefit, that's our ultimate goal. That means every insurance plan has to require coverage. So this is where we stand right now. You can see, and basically what this is broken down into is if you're on the national exchange versus the state managed exchange. Don't get into a bunch of details about the Affordable Care Act, but again, if you're federally managed, essentially you do not have coverage under those plans for the essential health benefits not listed. And then the under 18, again, very minimal coverage. So this is the big thing that I think was a shock to me when I started learning to deal about insurance companies. And I think this will be the biggest shock that you will see going out into practice, that even if the patients that will come in to see you will have some form of health coverage almost always. They will have commercial insurance, Medicaid, Medicare, et cetera. However, having coverage for insurance doesn't mean they have bariatric coverage. And when they have bariatric coverage, it doesn't mean they have actual adequate coverage. So what you find is that even when people have bariatric coverage, they may have excessive requirements and barriers written into their plans. It is very common at this point to have a 6-month dietary requirement where the patients have to come once a month for 6 months before they're even considered for surgery. And again, this is where I get passionate about what we do. I mean, could you imagine telling someone, well, you have diabetes and we're not going to give you any medicine or any treatment for your diabetes until you've, been on a diet for 6 months, show us you can show up and be there. Then we'll start you're treating your medical problems, or we're going to make you wait 6 months before we take out your colon cancer. I mean, this is unheard of in any other medical specialty. There's a lot of requirements where the patients can't lose weight. They can't get, if they lose weight during the process, well, they're successful and they can't have surgery. There's other insurance plans that say, well, if they gain weight, they're not being compliant with their diet, therefore they can't have surgery. So there's such an excessive amount of requirements that occur, again, with bariatric surgery and comparative to anything else. Once per lifetime surgeries, this is a big issue that we see. It's becoming less and less. This isn't as ubiquitous as it used to be. But there are so many people, especially with the band surgeries, bands are still being performed and it's a recognized procedure, but the volume has certainly dropped, by 90+%. But those patients that had a band, and some were successful, but some weren't. Well, now they want to look seeking another operation, being converted to a bypass or a sleeve, and they can't have surgery because they have this limitation written into their plan. They also have disproportionate copays. This is something that has also been a kind of, oh yeah, they have coverage, but the reality becomes in, if someone has a, cholecystectomy, they might have a, $1,500 deductible or a $2,000 deductible. Well, if they want bariatric surgery, they have coverage, but they have a $6,000 deductible. And so again, it's a discrimination against patients that suffer from obesity. We see this, frequently. In my own system, when I started the current place I practice, they had a different copay for the employees seeking bariatric surgery, and they also had they refused to give the patients any opportunity to make payments like any other medical debt. Usually you can make payments to the hospital, $200 a month or whatever the patient can afford. For bariatric surgery, for all of our patients, they had to pay their $6,000 copay up front, and there was no exception to that. So, and then the extreme workup and documentation, to give just an example, the workup process, there are as many insurances that require, cardiac evaluation or pulmonary evaluation. Even if you're 23, don't smoke, and have no comorbidities, you still have to see a cardiologist and a pulmonologist because that's the way they've written into the plan. Where they have to have sleep studies if they're asymptomatic, just things like that. And the documentation level. So, my practice is kind of narrowed down into doing bariatric surgery and endocrine surgery. So that's the two areas of practice that I have. I'll do gallbladders occasionally, things like that, hiatal hernias, foregut surgery, but primarily that's where I focus. So if I do a thyroid on somebody, to get a thyroid, I can see the patient that day, refer for the endocrinologist. They're ready to go for a hemithyroidectomy, and my insurance coordinator faxes in one sheet of paper. Usually within that day, they get a fax back saying that or email documentation back saying that the surgery is approved and can be scheduled. For bariatric surgery, it takes us multiple months, multiple workups, and typically the paper that is documented that has to be sent in is usually an inch thick. And I've had surgeries denied based upon one sentence that we didn't document something that we do document in an inch thick stack of paper. So it's just the disproportionate requirement that, burden on your office is substantially different. So that being said, we want to talk a little bit about some of so again, I hate to bring up a lot of, it seems like a lot of frustrating barriers, and it is. The rewards are very beneficial. The rewards of doing bariatric surgery are fantastic, but the hurdles are also there. So we'll talk a little bit about access to care and some of the things that we have accomplished and some of the things we have to work on very quickly. So this is the new area that we're really pushing, and this is a tremendous amount of patients, which is why it's resistance a little bit to the insurance companies that the standard BMI requirements, the lower BMI requirements of 30 to 35 with type 2 diabetes. This is a tremendous amount of patients in our national population. So we've worked really hard on this topic in the last 12 to 18 months, and we've added a lot of regional plans where we do have coverage now for this low BMI group. However, there is, again, a lot of restrictions. Most require hemoglobin A1C control of less than 7 or 8. Again, they want to demonstrate compliance with a medical regimen before offering them surgery, which is not unreasonable. And even if your patient does have a high BMI, which is common, you can get around this if you have documentation of compliance from an endocrinologist. So when you look at where we've been successful, these are the plans that have coverage now. We've added even more since volume of patients, but these are the plans that cover it right now. So we're estimating, this is what we have for guarantee. We don't know some of the numbers, but it's around 4 million covered lives now that have coverage for low BMI and type 2 diabetes. This is a big win for us, as this is one of the primary reasons why people seek out, from a medical standpoint, having bariatric surgery. So we made a lot of progress last year with Anthem. So this is one of the largest plans in the United States. And they had historically always had a 6-month diet, a process where every patient had to go through a 6-month preoperative program. So we changed this last year, and now patients the documentation states that they must participate in a multidisciplinary program, which is essentially almost every program that we have, or as a accredited center, the MBS AQUIP program, you're a multidisciplinary program. So this was a national coverage decision. So this was a big win for us from a bariatric surgery standpoint, where we can get our patients through in a much more efficient process. So while this is improvement, it's not 100%. Again, I always describe my job on the Access to Care Committee as the most depressing job I've ever had. Well, you learn a lot about insurance companies, and you realize that, well, they can make a national coverage decision from Blue Cross Blue Shield and Anthem, but the next level down, the regional medical directors that typically control multiple states, they can override a national coverage decision and still put in a 6-month diet. So the farther you go down, the more control that the insurance plans have. Also, a business that when you go, they sell insurance plans to businesses, they can request a 6-month diet. They can say, well, we want that in place. Well, and you ask, well, why would somebody want a 6-month diet onto their business plan? So again, to get around this coverage decision, they will go to a business and say, hey, we will sell you a plan for X dollars. Bariatric has insurance and bariatric surgery coverage. But if you add a 6-month diet to your bariatric surgery coverage, we will take 10% off your plan. And so businesses that, are trying to, be as efficient as possible will say, that sounds great. We'll just go ahead and get the cheaper plan. So again, there's a lot of ways around this, but this is 30 million covered lives that we've added coverage to, or taken away the 6-month diet. And now we'll go through this a little bit quick. They had a 3 and 6 month plan. We met with them multiple times. This is a lot of help. There's a lot of advocacy groups out there that help you, especially the OAC, the Obesity Action Coalition with Joe Naglowski. They really helped and pushed this. They eliminated those 3 to 6 month plans and changed this to a 12 visit plan, with almost any visit will count toward this. So this has been a very positive response, and that's added over 20 million covered lives that no longer have this kind of abusive 3 to 6 month diet. Same thing, UHC and Cigna, we dropped their 12-month. They used to have a 12-month criteria. They had to come once a month for 12 months. We've altered that for most plans nationally. This is some of the areas we have with a hurdle. Why I said, most patients or most programs don't perform a high percentage of bands any longer. The Optum Center of Distinction came out with a new process last year that said if your volume is greater than 5% adjustable bands, you're eliminated from the Center of Distinction, not for doing bands, but for doing any bariatric surgery on UHC patients. Not complication related, not outcome related, just if your volume of bands is higher. So again, this is a pretty abusive. It only affected a handful of centers, but again, this is where the insurance companies can dictate what we do. So again, I want to save a lot of time for questions, but Blue Cross Blue Shield, they modified their criteria. We report our data to be a center, be an accredited center. We report our data to the American College of Surgeons, and we get a semi-annual report. So twice a year, we get a report on our data. It's comparatively, it looks at our outcomes. And so they decided to use, we have to provide this data to the insurance company. So they selected a line in the sand where if your lower confidence interval on 5 different criteria is greater than 1, you're eliminated from being a Blue Distinction Center, which again, for me, for example, would eliminate about 65% of my commercial pay patients. So anyway, so it's not database, it's just they've taken this line, and this is the new criteria that they have, and their goal is to eliminate centers across the country. It's kind of a stated goal. They want to, decrease the footprint they have to coverage surgery. So this is a continual battle that we have trying to fight with them to eliminate that process. Revision bariatric surgery. This is this is actually the largest area of growth in bariatric surgery right now. Our numbers nationally are pretty flat. There's a small amount of growth, but the area that's growing is revisions from, bands or older surgeries. And this is becoming, as this volume increases, this is becoming a target for insurance companies. So there's a lot of, these are very hard to get approved, but there hasn't been very many specific insurances talking about revision other than once per lifetime surgeries, so to eliminate it. But there's been a recent change in two major regional plans in West Virginia, Ohio, CareSource. This is one of the primary Medicaid companies, that they've put in a plan that said enlarged or dilated pouch is no longer an indication for revision surgery. So they're kind of taking the first approach to limiting what we can do. If a patient does have weight recurrence or need a revision for any reason, they're eliminating essentially weight recurrence or this documentation. You can't have surgery, revision surgery any longer. So the big concern is this is the first of many. I think this is going to be a trend, what I see nationally, that they're going to really start scrutinizing what we do for revision surgery. So what's our future? So we've made a lot of progress. We still have a long way to go. We're working, from overall general surgery that CMS is, there's a whole other talk about CMS looking to reduce the payments to surgeons. They consider medicine a zero-sum game kind of process, where they want to increase payments to some of the non-surgical specialties, and that has to come from somewhere, which is us. So they proposed a 10% cut that was defeated last year. This is coming up again in the next 2 to 3 years. We'll have to do this again. We still got to work on Blue Cross Blue Shield, and we need to expand our access. We should have better coverage. As I'm sure you guys have heard a million times, we operate less than 1% of our patients that are eligible for surgery. So we need to do a better job getting access and getting our education process out there. So the first place to start, I always say, start at home. When you start your new career here in a month or two, if you're working in a hospital that is a bariatric center and your employees in that hospital do not have coverage, you need to fix that. That's a basic basic process. And then our ultimate goal is essential health benefits, being listed as obesity care on the essential health benefits. So the other thing is I challenge each of you to don't accept what you see. Don't take no for an answer. Advocacy is important. There's a lot of people out there. Dr. Dan has been a great help to access issues in our own state of Ohio, but all across the country. It's one person that usually makes a difference. It's one person that starts it, usually in your state chapter, or takes an issue and brings it more and gets more people involved, more surgeons, more patients involved. So be active. Do employer outreach. Talk to your insurance medical directors. Don't let no coverage be the final say for your patients or for yourself in your practice. So I always not only did you motivate yourself, but motivate your patients. As important as your voice is, your patients even carry a more powerful voice. So motivate them to take action with their employers or with their state legislators. They will listen. So this is my thing always too, is to take one day out of your practice. Don't schedule office, don't do rounds, you don't have surgery, anything. Take one day a year and make that your advocacy day. Make phone calls, organize patients, do something to help improve coverage for your patients that you're seeing. So take one day. So thanks you very much for having me participate in this. This is my email. I don't mind anybody that I give a lecture to ever give me a call or send an email. I'm happy to answer any questions that you have in a moment. I stay abreast of what's going kind of in the job world for bariatric surgery. So ask questions about access or getting started in your practice, things like that. I'm happy to answer those. So thank you very much.
Thank you very much, Joe. Wonderful presentation and a great review of some of the hurdles that exist out there right now. We're going to save the questions for the Q&A session. I know that I've already got some written down, and I'm looking forward to them, but we'll transition directly to Mr. Lindstrom's talk. Walter.
Okay. Thank you very much for letting me play in your sandbox. Being a lowly legal professional as opposed to a physician, I always feel overwhelmed when I'm in the presence of such greatness. I'm going to see if I can get my presentation up here. And there we go. That's the Hotel Dow in San Diego, where the 1999 ASMBS meeting was held. these are my disclosures. My employer is the only ongoing financial relationship. There are some other disclosures that were alluded to, which is this past Wednesday was my 27th anniversary of my gastric bypass, and I had a BMI of approximately 61, and I show these slides just to let everyone know in the audience that you can be a great dresser and still be morbidly obese. All of you wish you had pants like that. But here's the 30,000 foot view of bariatric and metabolic surgery. You might see BMS as part of what the abbreviations are, because truly is, either MBS or BMS. The metabolic aspect of this really needs to be emphasized, I think. I think this is dovetails nicely with what Dr. Northup said. All insurance is local, and that is incredibly important. Wherever you end up starting your career, if you're going to be changing regions, changing states, the payer challenges are going to also vary. Dr. Northup's issues in Ohio are quite different from what Dr. Jain-Spangler is dealing with in North Carolina, or what practitioners here in California deal with. So what you need to do in order to understand what your issues are is, once you get settled, go to your faculty, and also go to who I call the brave first responders, and those are your insurance professionals. These folks have a very inglorious job. It is really hard. It is very frustrating. It takes significant skill. Their expertise is often unrecognized. Go introduce yourself to them, find out a little bit about their world. I can promise you that relationship will be extremely beneficial for you. In terms of what I'm going to talk about in the time we've got, who the players are in this landscape. You've got a load of governmental payers already alluded to by Joe. Medicare, Medicaid, and TRICARE, the VA. You've got the Affordable Care Act marketplace, there's state coverage, all of those things that talked about. All of the coverage, payment, coding requirements oftentimes are generated by legislation or by administrative entities charged with, departments of insurance, departments of managed health care, and they will have a process set up as part of their statutory scheme to challenge denials, and those rules are going to be a little bit different than what I'm going to talk about. Let's save that battle for another day. Let's focus on the commercial insurers, because I think that's really where the rubber meets the road in terms of advocacy. Most of us get our health coverage through employer-sponsored insurance. It's an extremely bizarre course of events as to why that happened, but it's a benefit of employment. And with that, there is a host of issues that you have to start out as a surgeon understanding a little bit about. Employer and sponsored insurance can be self-insured, meaning that the plan, the Xeroxes and the Apples and things like that are paying the claims. It could be fully insured, just like your car. You pay a premium and you get coverage for health insurance. You have this strange phenomenon that is largely unrecognized by surgeons, that you may have a Aetna or United Healthcare acting for one of your patients as the insurance company, and for another situation, they'd be acting as a claims administrator and not insuring things. So you'll have to get the lay of the land as to what roles the Blues will play in your particular area. The commercial insurance field is governed by multiple statutes. HIPAA comes into play, COBRA. Most important, you'll hear this term called ERISA, the Employee Retirement Income Security Act of 1974. That generally, with a few limited exceptions, state groups and church groups and things like that, is the statute that really governs everything with respect to health insurance. How plans look, how they've got to read, the paging, the size of the print, what the coverage requirements are, and perhaps most importantly, the appeal procedures for when things are denied. So ERISA is a word that you might be hearing, and you should be aware of it. Joe alluded to this, contract exclusions, and I think that it's important to know that's often your patient's most significant challenge. I want to show you an example of an exclusion that is found in a health insurance policy for medical surgical services intended for the treatment or control of gastroesophageal reflux disease, including that accompanied by hiatal hernia with or without esophagitis, anti-reflux medications or treatments. That's an exclusion for acid reflux. And guess what? You will never, ever see an exclusion like that because no policy of insurance excludes GERD or cancer or heart disease or diabetes or arthritis. And the reason for that is the underpinning, and I get very amped up about this as a patient. Those are considered by the insurance industry and society in general, unfortunately, as real diseases. They're worthy of being covered versus obesity, which is not. And so you have to be aware of the underlying bias that's involved. This is the real exclusion. Take out the GERD and you can see medical, surgical, initial and repeat for the treatment of obesity, including clinically severe morbid obesity. This is the kicker: medical and surgical services to alter the appearance or physical changes as a result of any surgery performed for the management of obesity, weight loss programs and treatments, whether prescribed or recommended by a physician. This is a real insurance policy, folks, and this is not unusual. This is a Cigna plan. Not only is it trying to deny access to metabolic surgery, but it's also trying to, at the same time, get rid of any medically necessary reconstruction. This is the kind of frustrating thing your patients deal with and things that you're going to be dealing with. It's a brick wall that you're going to be running into. And it's impossible in the time we've got to go over all of the different aspects in detail, but you've got contract exclusions for diseases like obesity. You'll see contract exclusions that specifically say gastric bypass, gastric banding, wiring of the jaw, balloons, things like that. Those are things that your patients are confronting all of the time. That doesn't mean they can't be overcome, but they are incredible challenges. Joe's already talked about the unreasonably restrictive medical policies, of which mandatory supervised weight loss is one of them. ASMBS came out with a position statement denouncing these. You have, all tout the society when you join it and you become active with it. You will discover an amazing group of people I've been a member since 1996, I believe, and I've met most of my dearest friends out of this society, but you'll also find that there is a tremendous amount of resources, toolkits, access to care toolkits, and a collegiality where you can email people and talk to them and find out, hey, how did you deal with that? So understand that that's all there for you. Joe's talked about revisions and conversions, and that's 90% of the appeals that I handle now. And I put it down to let's blame the patient. He put up the slide that says they're not going to cover weight regain and things like that. And you will read, and these are really mean-spirited, awful exclusions that, again, you wouldn't see it in any other framework of any other kind of disease. You'll also be dealing with special circumstances. Adolescents have a certain protocol that needs to be followed, and there is an older style measurement of Tanner scores that has been abandoned by ASMBS, again with a position statement that will guide you through what the insurance companies should be looking for. SOTI is a procedure that's on the rise, but there are other so-called experimental or investigational procedures that you'll be challenged about. I am a big proponent, and again, Joe had the slide up before about diabetes surgery, BMI of 30 or above with type 2 diabetes. Other issues include doing a Roux-en-Y strictly for reflux in the obese population, again, per recommendations of SAGES and ASMBS. You've got a lot of issues to confront, and the first thing to do is to understand that they're there. And then how do you fight them? In terms of challenging a payer denial, the number one thing that people always think about as physicians is the whole peer-to-peer conference. And I put a question mark next to peer, the second one, because when you are dealing with this process, it is a process it's your right to raise in many circumstances. And it can be an effective way of getting cases overturned, usually when the insurance company's medical policy is not at issue. Most of the time, when there is a challenge to the medical policy, you'll get a medical director. It turns out to be a podiatrist or a plastic surgeon, just about anybody who is non-surgeon. You'll deal with folks, and it'll be very frustrating for you. And then they'll throw up their hands and they'll say, yeah, well, doctor, it sounds very good, but unfortunately, this is our policy. I can't overturn it. They are sometimes very frustrating to put together. And so it is an option. It can be a very viable option. It helps you to develop relationships with medical directors, but it certainly isn't the only way to challenge a denial. There are others. And what I wanted to raise is the patient appeals process is I call it an internal appeal because it's a process controlled by the payer, and you can have one or two levels of appeal. Can't have more. An insurance company cannot set up a plan that says you're going to have 5 levels of appeal before you have to go to some other process. ERISA, controls this and says you can't have more than 2. Here's the problem, though. This is a right that belongs to the patient, and it is often misused by well-intentioned practices who burn up patient rights, not even realizing that they don't have an unlimited number of appeals. If that's one of the takeaways that I can drive home, is that in the commercial context, this isn't an unlimited process. This process could include an external peer reviewer, somebody that might have the chops to make the decision, but that's not necessarily an independent reviewer. That's a different process. That's item number 3. Once you've exhausted the internal appeals and you haven't been successful getting an Anthem or a Blue Cross or whoever to overturn its own denial, you can't fret. And this is something that I cannot stress enough, because the independent review process is the single most important mechanism that you can be aware of, make your patients aware of. You will be able to participate first as somebody who is ensuring that your patients do get a full and fair review by a colleague, by a bariatric surgeon. And eventually, when you've eaten a few beans, as my dad used to say, you too will be able to be one of those independent reviewers who will be able to positively impact the payer landscape by making individual decisions on cases. And the reason the independent review is important, and the reason the independent review is important, is because all of the nasty stuff that Dr. Northup talked about in his presentation about these criteria, which are truly heinous, an independent reviewer doing his or her job is not bound by that payer criteria. And I wanted to just, leave you with the idea that, I won't read this whole slide, but this is the opportunity, oftentimes the only opportunity, to have somebody not affiliated with the carrier, with the insurance company, and somebody who's going to make a decision based on, this is a listing that comes from the statute that bore all of this. The most appropriate practice guidelines, which shall include evidence-based standards, other practice guidelines developed by the government, national or professional medical societies like ASMBS, the opinion of the independent review organization's reviewer after everything that they review, items 1 through 6, they can look at anything and they can make a decision based on what they think is appropriate. If they think that a mandatory weight loss program for 6 months prior to surgery is bogus, which it is, then they can overturn that. And it is an incredibly powerful tool. And still, after all these years, it surprises even some of the folks that this option exists, and that when they hear about it, they get very excited, and as well they should. So the process is from 30,000 feet. You're joining a fight, and we thank you for joining the fight, because this is it was the single most important health decision I made in my life. You saw my daughter, she's now 27 years old. I made it for her and for her sister that followed years later. The fact is that getting people approved, turning no's into yeses, there, in my practice, that's the glory, and that's the reason I do what I do. And I just really appreciate all of you having the passion to sit through a presentation like this and have the interest to take part. So I think with that, I will conclude for questions, however that's going to be handled.
Thank you so much, Walter and Joe. Great presentations, and really a great combination of lectures to to give our graduating fellows and faculty out there a true unique perspective and comprehensive perspective of all that is involved in taking care of these patients. I'll start with a quick question, and then we'll take some from the audience also. Please feel free to put them in the Q&A. Joe, first one's for you. Two-step approaches to severe refractory morbid obesity is becoming a true part, a very important part of our algorithms when you see the patients with BMIs of 80 and 70, severe diabetics who cannot withstand a gastric bypass or a SADI in one shot. We know it's a chronic disease, but the insurance companies are targeting this and defining them as a failure of the initial operation when truly it is a part of the treatment. How do we fight back? Because that could go both ways. We could be blamed for that. We could look at it as the right way to treat the patient. So what can we do?
Well, I think the biggest thing, Adrian, is to start documenting early. If you're truly planning this as a two-stage procedure and you submit it that way, and you submit, let's say, typically it's a sleeve gastrectomy, then a conversion to a roux or a SADI, as you said, when you submit that, they will just look at that as a sleeve gastrectomy. So I think when you are planning this, have very clear documentation of what your plan is, the high BMI, the risk, and put that up front. And that way, when you go back for the second surgery, if there's a issue with, denial or something like that, you can go back and say, look, when we submitted this is how we planned. This was a two-step process. And I think sometimes it actually works better when the patients are successful. And most of these patients are, right? They take their BMI from the 70s down to the BMI in the 40s or 50s. And I think so documenting that they've been compliant with their follow-up care, that's always critical to getting a second procedure done when it's planned, and then showing their success. And that, I think those are the best steps to take.
I have a quick question. Yesterday I did a peer-to-peer and I felt like I was banging my head against that brick wall, Walter. And so I was hoping one or both of you could comment. The peer-to-peer was for an insurance company who is requiring my patient to be admitted as an outpatient sleeve. And I know this is becoming more routine, probably for some areas. We do often have higher acuity patients where I practice, and I'm not comfortable booking every sleeve as an outpatient surgery. Often they do go home within 23 hours. However, I like having the ability to keep my patients for longer than one night if I need to. And what I was told is 90% of the time it gets approved. And I said, well, what about that 10% where my patient's going to get the bill? And they said, oh, no, the hospital will absorb the cost. So what are your thoughts about this becoming more routine? How do we handle it? And what should we do as surgeons moving forward in these situations?
I'll leave that to Joe. This is right in his wheelhouse.
Yeah. So thanks, Kunoor. So the outpatient surgery, this is the next big thing. And again, being, doing a lot of access work, it's funny when major players, there's always a shift in the insurance court and the medical directors, I should say. When there's a new medical director comes along that he or she decides that there's going to be I'm going to change this, change that. All of a sudden my emails go off and from whatever region that they're seeing. So nationally, we're seeing a big push towards outpatient surgery. And to be clear, there's a difference between same-day surgery, for the fellows, same-day surgery and outpatient surgery are two different things. Same-day surgery is where you gallbladder, you do the surgery, they go home the same day. Outpatient surgery is whatever the insurance company decides it's going to be and paid for less. So, and so the issue is, so for most of us, sleeve gastrectomy, as Kunoor said, that you're home in a day. Typically the post-op day one, you're going home 23, 24 hours and but they're in the hospital overnight. Many people do a post-op upper GI, your entire process there. So that is, that's how it's done, and you get reimbursed for yourself and for the hospital. And so what the push to doing outpatient surgery is, you're going to do the same process. You're going to be allowed to admit your patients overnight, but the hospital and you are going to get much substantially reduced reimbursement. That's the push. And, again, I think it's where we're using our data against us is what is happening. We've become very successful with good outcomes, and the processes have reduced the risks to our patients. And so along with that comes a push to say, well, gosh, this is a cholecystectomy or an inguinal hernia. And they're not. These are gastrectomies and major abdominal procedures. So I think this is where we're going to have to dig our heels in the sand. This is going to be, again, the next fight in the next 2 years is fighting back against forcing us into outpatient surgery. And a lot of it is dependent upon just your reimbursement. I hate to say that. So it's not the biggest issue, but it's not for your own personal finances, but your program, your dietitians, your coordinator, that comes from the money that's profited from or not even profited. That's part of the cost of doing business and quality care. And that's what pays for that. So it's not, you're going to make more or less money in your pocket. It's not about personal reimbursement, but your program can be impacted by a shift to outpatient surgery.
Thank you.
That makes sense?
It does. Yeah. We have a few more questions coming in. Tuesday Cook, stirring the pot. So with denials, I often have the patients write letters to the Maryland Insurance Commissioner. Has anyone ever encouraged a patient to sue their insurance company?
Oh, I'll jump on that. Since I've been doing this, it happens all the time. And it's, like I said, it's the two favorite words of every physician that I ever have a conversation with is class action. We've got to have a class action. And they don't realize that this is not amenable to that. So please, all you fellows, strike the words class action from your lips when it comes to this. You can't sue your insurance company until you complete the steps that I just alluded to. You have to exhaust your other remedies, including the independent external review. Then what happens is if you do file a lawsuit, in most instances, the cost of that in terms of time and dollars is going to be more expensive than the actual case itself. And that's something that has to be weighed. You never are going to have a patient be able to go from an initial denial to a lawsuit. That's simply not the way it's done. And lawsuits, while they sound like they are the kinds of things that will strike fear in the hearts of an insurance company, they have entire departments of people whose job depends upon people suing that insurance company. So it doesn't really strike a lot of fear in their heart. So lawsuits that's really why I started the practice I did. Non-legal, non-judicial, the appeals process, it's the most powerful tool that patients have, and it's accessible to virtually every patient.
Thank you. We have another great question that is very pertinent to our graduating fellows. So when moving to a new state and starting a new program, what is the best way to keep up with the frequently changing requirements with so many different insurance providers with a wide range of criteria for approval? That's question number one. Also, how does living in a tri-state area affect coverage across state lines?
I think these are good questions, and keeping up with the insurance process is a daunting task. There's a new program coming out through industry, through Johnson & Johnson. They're actually going to have a searchable database. It should go live in the next 3 months. I'm stealing their thunder a little bit, announcing this, where you can go in and plug in a plan, and they will give you the criteria and a link to that plan. I mean, this is hundreds upon hundreds of plans. This is an exhaustive resource that they're providing. So that will be one way. One thing in bariatrics, you will have some access to an insurance coordinator, and it is a full-time job to track these plans and make modifications and understand how the changes are occurring. And there are services out there. We utilize the service now where if we don't know the insurance, my coordinator doesn't know, we pay a service, and they will, we send in their information. They send back whether they have coverage or their criteria, things like that. So there's a lot of options that you have. And it's if you're starting a new program, you will find this a great source of frustration. And, but it's part of the process, and it's a learning curve. So you'll figure that out. As far as your being in a kind of tri-state area, we have a similar issue here where I'm an employed physician currently, and we're banned from seeing certain types of Medicaid that doesn't reimburse enough for my system. So, the process is different. So we're banned from seeing those. Some commercial payers, not many commercial payers, but a lot of, again, the state funded plans will ban you from doing surgery outside the state. So you will have to deal with that. Some will, some won't. And a lot of this is going to be trial and error. The best thing is open up your seminars, try to get as many people as you can, and you will start learning the process of, what you can and what you can't do. And depending on where you are, that's again a great access fight to have. Again, I'm in the Cincinnati area, so right on the border of Kentucky. So we see patients from Kentucky a lot. We're the big city in this area. So it's a little easier. My process over years, it has adapted where, you can get care in Ohio because you're right across the river. So if you're the big center and you're going to be doing a lot of the bariatric surgery and there's nothing on the other side of whatever line, that's an insurance fight you need to take to the insurance company and try to say, look, we're providing care here. This is we're a service area, and try to get your facility or this rule adjusted.
If I could chime in on that as well, I think one of the things that we've always taught newer practices is to figure out there's usually a dominant set of employers, core employers in the area that might be funneling more higher percentage of patients. You got to find out, you got to get copies of their plans and actually look at what their coverage is, because like I said, it's all well and good to know that they've got an Aetna plan, but is Aetna acting as an insurance company? Is Aetna acting as an administrator for something that doesn't involve their medical policy? There's really a lot of parts of the onion to peel. And so it's taking that insurance coordinator out to lunch and really picking his or her brain to learn the lay of the land as quickly as you can. And, there's usually a payer hierarchy, 80% Blue Cross Blue Shield Alabama and 20% of no coverage with everybody else. I mean, you'll learn who the dominant insurance companies are, dominant employer base groups are, and it's a lot of trial and error.
To bring up another comment, Walter brought up a great point. I love talking about the fellows about getting started and how to get their practice going and things like that. So two things. One, with telehealth. Right now, telehealth, we're pretty much allowed to see everything with the Affordable Care Act, or not the Affordable Care Act, with the COVID relief bill. But in the future, this is all getting ready to change right now. Who we can see. So if you're in a tri-state area like that, sometimes it's worthwhile to get a state license in multiple states, especially if you're doing telehealth. That's going to be a big issue. But Walter brings up a great point, and this is something that I did a while back, and it's to get your practice going. So find the businesses will cover it. Like, find the large businesses. So the county chamber of commerce is a great place to go. They will list every business that is in the chamber of commerce and their employees. So I went through and found the chamber of commerce, found the biggest employees, who had coverage, who didn't, and I actually went to businesses that were, there's some big companies and big corporations, and I offered to do seminars for their employees at lunch. So I'd go down there and, do a luncheon seminar, and the employees in the building could just come down, bring their lunch, and, kind of give them an opportunity to talk about bariatric surgery. So I did that for any nearby county and the biggest businesses. And that really got me started. All of a sudden, one day you'll get, a handful of patients just from that. And then that gives more and more and more. So it's a good little trick to get started.
That is a great idea, Joe. I used to call them lunch and learns.
Yeah.
And then sometimes we'd go to other offices and call them snack and chats. But they're very useful ways to get information out there. And I mean, all of this information, most graduating fellows don't really think about these issues, but for bariatric surgeons, these are just huge issues that really will be important for the rest of our careers. So thank you both so much. This was a fantastic session. I don't think we have any other questions. So Adrian, I think we are good.
Yes, excellent. Thank you. I'm going to ask one more thing. If you guys can tell us a little bit about the Obesity Action Coalition and how that fits into this whole initiative.
There's a lot of great resources. Walter's a great resource, honestly. So we refer to him as the hand grenade in the office. So when we have patients getting frustrated, messed around, we like, that's the place to go to get revision surgery. He is a great advocate and is very successful getting things done. Another great resource is the Obesity Action Coalition, which is a not-for-profit organization that incorporates patients it's a great resource to send patients to do advocacy work. So if the legislative talks and discussions are great, you can go on there and say, well, who's my state legislator, who's my national legislator, my senator, and they will be able to direct you right to their office. So it's a great place to send patients. And just they have a 60,000 member group. So again, it's all patients and it's a big voice. So getting yourself and your patients active in that group is a great opportunity. When you have trouble, that's a great place to send an email, and they will take action, and they can respond to your issue with your insurance company or the employer or whatever with the 60,000 plus member voice. And they can really help move the needle. Like, Aetna, for example, getting rid of their 6-month diets, that was almost all in Joe Naglowski and the OAC. They did such a great job, getting information and talking to them and sending emails, and they help push that needle. So it's worth a few minutes to go check out their website. Tons of resources on there, and it's been helpful from a national standpoint. I utilize it all the time on the Access to Care Committee.
I was honored to be on the board of directors, the national board for OAC for several years, and it is an amazing and powerful organization. If you are interested in state advocacy, they'll coordinate with Chris Gallagher at Potomac Currents and get you in front of people. You can participate in a day on the Hill and do visits to your national Congress people, your senators, their staffers. It's an incredible experience. Every fellow should do it early in their career to really understand how the process works. And I'll echo what Joe said. Go on their website, just start clicking, and you can't click and not get incredible information. So it's a go-to resource to get a lot of good stuff.
That's a great content. Anybody that wants to participate and do a Hill visit, which is it's really interesting process, and something, again, everybody should do it once just to meet with your own representatives, but we can help arrange that. We provide training to how to interact with them, and then we have so many advocacy days per year, like until COVID happened, but restarting those. But if you want to participate and go to Washington and experience that process, let me know, and I'm happy to help arrange that for you.
Thank you very much, both of you. I'm going to leave the fellows with a couple words here, just a couple plugs. If you want to make advocacy a big part of your practice, I want to plug Dr. Joe Northup's article in Bariatric Times, which is coming out in July, where he will give you a recipe on how to take one day from your practice and make it worth your while to advocate for your patients. And also a reminder that access to care issues are not limited to the United States. If you get a chance, there is a free documentary about the national healthcare system in England. It's a BCC documentary, or BBC rather, I apologize, from Dr. Rachel Batterham. And it really shows you what some of the hurdles are across the ocean with lack of understanding of the true roots of obesity, and how it impacts up to 230 other conditions, including the ones that Walter mentioned. So with that, I want to thank you all for attending our seminar series for the course of the year, and I wish you the best of luck in your future careers. Reach out to us if you want to become involved as a lecturer, as part of our committee. And I'm going to leave you by thanking Dr. Joe Northup and Walter the Hand Grenade Lindstrom one more time for their great expertise and for taking their time. Thank you, everybody.
Thank you.
Thanks, everyone.
Thank you.
Judy, Chen here at the University of Washington, Seattle. I again want to applaud the ability to have the time of Dr. Northup and Walter in regards to your expertise and, just, gosh, cannot believe all the things that you both have done for the advocacy for our patients and just the national changes you've brought. So thank you. There is one question in the question and answer, which I'll start with, but otherwise, please, in the audience, please feel free to take this rare opportunity to reach out. The question from an anonymous person, what is the progress with Medicare and low BMI of 30 to 35 with diabetes. And open that up to either Dr. Northup or Mr. Lindstrom.
Yeah, well, for Medicare, CMS is really one of the tougher insurance companies to deal with. It's a much more, as you can imagine, with your government, more of a bureaucracy, and getting the low BMI covered is very difficult. You can have some success people have had with looking at type 2 diabetes, but really that low BMI group is not covered, and CMS more of a push to get us listed on the essential health benefits. That's our primary goal. But yeah, right now it's not much of a push going on with them, and they're not very malleable to much change. Anything under 100 years they consider new. So
the thing about bariatric surgery, obviously, is that it is subject to a national coverage determination, an NCD, and that's really the way that everything is laid out. The nice thing with respect to diabetes is that it is separately recognized as a comorbidity that supports bariatric surgery. So that, is sometimes been misconstrued by local Medicare plans to be the only comorbidity, and the rest of them be darned. But getting the change to a national coverage determination is akin to an act of God sometimes, and there's only so many resources to get that. And I dare say that the Medicare population of people in that 30 to 34.9 range is not high enough yet to really have them take a hard look at it. I certainly haven't seen any numbers, and Joe's been my committee boss for several years. If there were numbers, he would have told us.
Yeah, and that's Medicare patients as a group nationally, it's certainly less than 10%, but close around 5% of most of our practices. It's really not a large number overall. There's some managed Medicare and things like that, but it's not a big number. We've had some success. Well, I shouldn't say success. There have been some regional Medicare directors that have really had very strenuous criteria, way beyond anything else. We've got them to move back to more normal criteria. But I think that the play for CMS will be as they're moving toward a bundled payment model. That's their big push right now, is to get everyone on bundled payments. I think there might be some give there where as we move into bundled payments, we can expand access. Hey, we're going to the bundled payment model. Let's expand access to cover these patients. So that might be an opportunity there, but we're still in the early stages of that.
Thank you. Please forgive me if I have this incorrectly, but I agree that locally, we can definitely make some changes, but could we ever get the NIH to go back on that 1991 criteria or any sort of movement away from BMI, in regards to the metabolics and then endocrine and
me.
Yeah.
Let me go first on this one, Joe, because this
Please.
is a pet peeve of mine. I read so many letters of medical necessity that have been, I drafted one that was circulated in ASMBS in 1998, and I still see my handiwork out there. People have got to realize that the 1991 NIH Consensus Conference has been archived. It is no longer active. Anytime that you utilize that, you're really citing something that doesn't apply. There are clinical practice guidelines that have been adopted that are much more expansive than the original 1991 NIH Consensus Conference. It doesn't address that fundamental paradigm shift away from BMI. That's more in the realm of the medicine and not bureaucrats like me. But I would beg all of the fellows watching this to not start with a document as the basis of their ask to a payer that no longer applies. It talks about procedures that don't exist. Technology is advanced, way beyond where things were. Yet there's lots of folks that hold on to that.
yeah, and so that's why I definitely started off, please forgive me, because this is such an opportunity, right? When I was a fellow, I never really got deep down behind these layers of barriers and just things on this side. And so can you, again, gosh, just that 1998, is that something that we should be talking to these peers of ours about? You know, these are all very old archived information that's still out there. Can you help me to, I again, beg for your forgiveness. 1998, what is the new 1998 thing?
Well, no, 1998, there's an NIDDK guidelines on the treatment of adult obesity. So you're not entirely incorrect. It's very frustrating for somebody like me who's in the trenches reading these letters, because, you know, and the fellows need to understand that it is their job as the surgeon to paint the picture that compels a payer who doesn't want to pay to cover this surgery. And they've got to do it with current data. They've got to do it with a reference to the clinical presentation of their patient. And you know, I have advocated and helped practices, you know, in consulting contexts, write their metabolic letter, because you should use a different letter if you're making a type 2 diabetes surgery ask. If you're doing a anti-reflux operation on somebody, either as a salvage of a failed band, failed sleeve, what have you, you can't just fill in the blanks in a template all the time and expect it to do the job. And so, you know, I think you are right to want to educate your colleagues, and certainly starting with, you know, this audience is tremendously important. But yeah, Joe, you need to get the word out. We need to do something about this. Maybe it's a panel, maybe it's a part of a course or something, because this is a key fault in how practices approach things. They just get busy. I don't say lazy. They get busy. They rely on what's worked in the past, even if it can be built. The mousetrap can be built better.
Yeah, I think you made some fantastic points there, and I think that's a great question, Judy, to bring up about how, you know, we have a very set in our ways, how we look at approach to doing our procedures and what the impact really is. And I think we are making some progress. I think it'll, you know, when you look at, to me, the low BMI and type 2 diabetes is more just strictly a metabolic approach to surgery. And, you know, as I said before in my talk, we have there's approaching around 4 million covered lives now. We have that coverage. This is a great advancement. We don't have any major players yet, but there's, you know, if you look at China, for example, their entire, you know, you talk about a one payer system, right? Everyone's is part of the government, and they actually have their criteria. If your BMI is 27 and type 2 diabetes, you can have a gastric bypass. And there's one insurance company, a small insurance company in South Carolina, that actually they added low BMI and type 2 diabetes, BMI of 30 to 35. And then they actually have a clause, if you're of Asian descent, you can have surgery for BMI 27. So that's the first one in the United States that I've seen. But so again, I think we're looking more of that metabolic approach. And when you get to do this sort of thing, when you talk, when you get the chance to go out and start talking, again, this is a different approach to being a physician, but you'll get a chance to talk to medical directors. One of the big pushes they have, and I've been successful in moving the needle, is talking about some of the cost issues. They know the cost way better than we do. And the cost of diabetes has gone up substantially. Insulin, I just assumed insulin was something you went to Costco and bought a bucket of it for $50 or something, and it's really expensive, especially the newer ones. So they're starting to see we're becoming more and more by the day cost effective of getting rid of diabetes and lowering the medication costs. So we're seeing a faster and faster return on investment. So I think that's where it'll be a push in the future as well.
Absolutely. I've had 2 patients this week without coverage. Mm-hmm. What do you say to your patients? Because, you know, it's just so hard. I feel, you know, just so without any advice, recommendations other than what's your spouse's? Did you have
Yeah.
a union? Can you try this? Because, you know, with the academic center, our self-pay is, I just not within patient's needs. I mean, I just feel like, what's your tools, or how do you communicate when you have that?
Yes, I think that's a great point too. So we all deal with this, and to be very clear, I guarantee they have insurance coverage. They just don't have bariatric coverage, right? So they have probably great commercial insurance, but they don't have bariatric coverage. So I being passionate about advocacy, I actually have a long speech I give to these patients and talk to them about. Usually they're in medium to small businesses, even though that's the largest percentage, that has the lowest percentage of coverage. They have commercial insurance, which is a smaller business, and they seek a cheaper plan. So my push is always to talk to the patient about being an advocate. The problem is not every patient's designed for that. Not every patient's motivated to do that. So I will say, look, one person can make a difference. We have coverage from CMS for sleeve gastrectomy because one woman wanted a sleeve gastrectomy that had Medicare, and she started writing letters and asking questions like, why can everybody else get this and I can't? And 10 steps later and a year later, we have coverage because of one voice. So every one voice matters. That's the first thing I'll tell patients. And the next thing is, to be active and be a proponent for themselves. Go to their HR and say, why does Medicare covers this? Every Medicaid in the United States covers this. Why am I paying taxes and everyone else gets the benefit, but I do not? So you need to go to HR. And I would say, look, you may not be something you're comfortable talking with, but I guarantee there's more than just you in your business that's thinking about weight loss surgery or concerned about their weight and has no coverage. Get 4 or 5 people together, gang together, and go to your HR director and say, why do we not have this benefit and others do? And I think mentioned in the talk, but a great resource is going to the Obesity Action Coalition. They have tremendous patient resources. You can go on their website, and I send patients there all the time. You as the physician, I've actually gone to businesses for medium-sized or larger companies that say, I don't have coverage. They say, if you give me the HR director, I will go there and talk to them, and I'll give talks to their administrative team about providing coverage. There's a lot of things you can do. And this is what I talk about, spending your day of advocacy. Find some large businesses in your area that do not have coverage and start communicating with them.
I'll jump in on that too, Judy, which is Joe just gave you the carrot. I'm going to give you the stick. When you say you get patients that come in that don't have coverage, that has to be proven to somebody like me, because I'll give you a couple of flip examples. You do a verification of benefits. You call up on the phone, here's the code. Is it covered? Somebody says no. I can tell you almost 30% of the time that's not a correct answer. The telephone verification is not 100%, whether it's a no or a yes. We're looking at a case right now where the verification said yes. Patient went down that pristine path of 6 months of diet and co-pays and everything else, had surgery, suddenly is being told that they, didn't have the benefit. I always look, I used to be a lawyer, and, I look at the contract, because the language isn't, always as ugly as what I had on my slide. Sometimes the language where they say a code isn't covered really isn't airtight. And again, it's comorbidity driven. Are you treating pseudotumor cerebri by weight loss? I guarantee you pseudotumor is not excluded. So are you looking at a disease-based exclusion? Are you looking at a procedure where it says, intestinal bypass, and they're claiming that that's a DS or a SOD-S or what have you? So, it's what we do. We look at the language, we figure out ways around it, because here's the important point. If a patient goes cash and has a complication, that isn't only catastrophic from a medical standpoint, it's also potentially catastrophic from the standpoint of coverage in the future. We had a case involved in your area where somebody paid cash and then had a marginal ulcer, and this was a late onset, 7 years later. They related it back to the bariatric procedure, and they claimed it was a complication of an uncovered procedure. I mean, cash isn't always the best thing for a patient, at least until they have gone through and exhausted all other alternatives. And practice is a real business, and oftentimes it's cash is pushed too quickly when the patient might be better suited to fight first, because they'll always be able to do the financing, write the check, what have you. So I think that's a really important point, is to don't accept their word for it that it's not covered. And we look at a lot of insurance policies and give a lot of advice on that, and we're happy to help anyone who needs it.
Wow, such words of wisdom, excellent points and inspiration here. So, I think the audience has not used any further questions, and we are up on time. So I do want everyone to have a safe and wonderful holiday weekend. I am on call, so pray for me. But otherwise, thank you for that fantastic opportunity to hear, your experience, your advocacy. This is what we all go into our fields of passion to do this. So I do thank everyone's time today.
Thanks for having me, Judy. Really appreciate it. Good luck, everybody.
Day. Bye.